Hi everyone, my name is Fabienne. I'm endocrinologist, like Heather said, in Sherbrooke. I'm French speaking. I prepared my presentation in English, so I'll present in English and I'll be happy to look at the translation afterwards, hoping my English won't be too bad. So I'll present to you and thank you for the opportunity. Sorry, I really want to thank you for inviting me. So I'll present on a big like an overview on diagnosis and treatment for newly diagnosed patients. So let's start with a little, resume of the physiology. So normal pituitary function. So do I have a pointer or can I use this and you can see here? Okay, but this works also here. So the pituitary gland, it's a little gland. It's the master gland. It's very important. It's located under the brain, at the base of the skull, and it controls many hormones and secretes growth hormone. Growth hormone will have an effect on the liver to produce its product IGF-1 that will have the effect, and the main one is in growth. So if you're a child and an adolescent, you need growth hormones. The levels are never to zero. They're always high. They can vary a little, and the area under the curve is higher, so leads to increased IGF-1 levels. There are many functions of growth hormone and IGF-1. They each other balance with retroaction and inhibition of one and another to have a good balance. The effects will be notable on skeletal bones, muscle, but also on other organs, notably the heart, the gastrointestinal system, the neurons, the liver, the pancreas, insulin production. So there's going to be a lot of other functions beside growth. Then acromegaly. So it arises from a tumor, a benign tumor in the pituitary gland that's going to secrete higher levels of growth hormone. Will act on the liver, and the production of IGF-1 will be increased, leading to overgrowth and metabolic dysfunction. There's a lot of clinical manifestations. As you can see on the pictures, a change in the facial features, hand and feet enlargement, some skin tags, many others, change in the jaw, the tongue is enlarged, the heart also, many other conditions like hypertension, diabetes, sleep apnea, headache are also very frequent, joint pain, bone disease, and there's others. If we talk about diagnosing acromegaly, it's pretty easy. If you think about it, you ask an IGF-1 level. If it's high, you have a diagnosis. So it's not like other disease, like Cushing's disease. You need to do many tests, salivary cortisol, urinary cortisol. For acromegaly, if you think about it, you ask an IGF-1, you can make the diagnosis. And the recent consensus on acromegaly diagnosis said that in a patient with typical clinical signs and symptoms of acromegaly, an IGF-1 level that's over 1.3 times the upper limit normal for age confirms the diagnosis. And the criteria for diagnosis evolved over the years. So if you had a diagnosis a few years ago, you might have a confirmation testing that was done with an oral glucose test. We don't really need that anymore if we have the high IGF-1 and the clinical symptoms. But sometimes we do need those tests, and we'll talk about this in a minute. But in life, it's not that easy. The challenges in diagnosing acromegaly is mainly in the screening part, because there's many barriers to diagnosis because people don't get screened. The condition is rare, so people don't think about it. The changes appear slowly and insidiously, so it takes a few years to notice there are some changes. And there's a lack of medical awareness also. So in general, patients consult 3 to 4 physicians before they have a diagnosis. Could be dentists, primary care providers, other specialists. They have consulted a lot, and people just thought about it a little too late. So the diagnostic delay, it's approximately 5 to 10 years. It's longer in women and with older age. And longer delay for diagnosis is associated with increased morbidity, so more conditions caused by acromegaly, and decreased quality of life, and impact also survival rates. So on the right, what you see is the number of comorbidities related to acromegaly, let's say diabetes, sleep apnea, bone disease, hypertension. If there's no delay in diagnosis, there's 2.5 in average at diagnosis, but if you wait and you have a diagnosis that's delayed from more than 10 years, you double these comorbidities. So there's some future in screening. You'll hear more about this today. Use of artificial intelligence is studied in research to help the diagnosis. So you'll hear more about this afternoon. Other challenges in diagnosis are cases of mildly elevated IGF-1. In those cases, we must consider the variability in the IGF-1 assay, which is the method used to measure IGF-1 in the lab. So I'll come to this in a minute. There are some factors also affecting GH and IGF-1, the weight, genetics, the diabetes, the control of the diabetes, the liver function, estrogen levels. So we should take this in account when we interpret the result. There are some false positive IGF-1 level, meaning that a small portion of the population has higher IGF-1 levels. It's their normal, it's not a disease, but it can cause mildly elevated levels on the labs. So what do we do in these cases? We will repeat measurements in a validated assay. And ideally, the doctor consult knows his assay. He knows how the results are either on the low side or high side, and the population on which we use the lab, we validate it in our population. And sometimes in this case, we'll need the confirmation testing with the glucose test. The expected response would be to have low growth hormone after taking the glucose load. So a growth hormone above 0.4 is diagnosis of acromegaly. So sometimes we will use the confirmation testing in these cases. But we have to keep in mind, and this is more like a new concept, that there's also almost 30% of mild acromegaly patients that will show a normal glucose test. So mildly elevated IGF-1 and a normal glucose test does not rule out. So we kind of need to continue if we think there's a clinical suspicion for diagnosis. And this graph is only to show the variability in the IGF-1 assays. So what you see on the graphs are the normal range. So the normal values of the lab. So let's say in between 10 and 40, that's normal. And if we use the same sample, and in this case, it was analyzed in 23 different labs using 6 different methods, those are the normal from the lab. So I draw a line at 40 just to show that if you have a higher IGF-1 and you were measured in this lab, you will have a normal value. But if you have in this lab, then the value will be high. So doctors need to know their test and use it wisely. And ideally, when you have, you need to monitor the disease over time, it's good to use the same assay during follow-up, because if you change lab, then it's going to change the normal, the values can change, so it's difficult to compare the results then. Next, when we've confirmed the diagnosis with the labs, we'll do a pituitary imaging. It's an MRI that we use with contrast. There's a special protocol to really image the pituitary region because it's pretty small, so there's thin section on the region to help see well that area. We're almost sure we're going to see something. So if there's acromegaly, the source of excess growth hormone will be in 99% of cases a pituitary adenoma secreting growth hormone. So it's a benign tumor of the gland, but secreting hormone, increased level of hormone. And what we're going to look at on the image is the characteristics of the adenoma. It will influence our treatment. So we're going to look at the size of the adenoma, if it invades the surrounding structures. So for the surgeon especially, this will be helpful to see if he can remove it all. And the appearance of the adenoma, we're going to look at some sequence that we call T2. If the appearance is either hypo or hyper intense, it's the tints of gray and white, then it's going to predict a response to somatostatin analogs, medical therapy. So on the image here, with the arrow, on the image on your left, you can see the gland. The pituitary gland is the little white area here, and the adenoma is the darker nodule. So I circled it. So there's a small one, a bigger one invading the structures. And there are some advances in imaging also. So there are some studies about functional imaging. It's a nuclear medicine, so it's a specific tracer that targets the growth hormone producing cells. For example, in this case, it's the 11C methionine. It's a tracer that goes to the growth hormone cells. And for example, in that patient who has been operated, it's difficult to see the residual tumor. There's some scar tissue. There was a tumor that has been removed, so it's difficult to look at the normal anatomy. But if you look closely, you need to have good screens to really be able to see it. But you see there's a little area that is bright on the right image, and this is the area where there's a residual tumor. So the surgeon will be able then to target and remove it all. Then treatment. So the objective of the treatment will be to normalize the labs. So this is one aspect. We'll aim for normal age-adjusted IGF-1 levels and also a random growth hormone that is low. But besides what we call the biochemical normalization, we'll also aim to improve quality of life, comorbidities, maintaining the normal pituitary function, controlling the tumor mass, and eventually reduction in the mortality risk. So what we have for treatment modalities, we have surgery, medical therapy, and radiation therapy. First, the surgery. So it's called the transsphenoidized surgery because the gland, which is located just here, so it's behind the nose, is more easily accessible by the nose. And this is the sphenoid sinus, so it's a little hole in the bone. So the surgeon can access the gland by this approach instead of opening the skull. So this type of surgery is the first-line treatment in most patients. It's the only treatment with possible cure, sometimes possible with medication therapy, but really less often. If the tumor is small, the chances of cure is higher than if the tumor is larger. But even in cases of larger tumors, the objective will be to remove most of the tumor without causing complications and eventually to help the medical treatment work better. And there are some risks. The pituitary gland is a small gland, so the tumor is there. The surgeon will try to remove the tumor without affecting the normal gland, but it can happen. Approximately 30% of the time, there will be low pituitary hormones after that. So the hormone control in thyroid and the cortisol secretion can be affected. There could also be after surgery a fluid leak, because if there's a little breach that stays on the bone, the liquid around the brain can leak from these little breach, and this has to be treated after. So it's a complication specific to that surgery. Also infection and bleeding, also possible complications. So it's important also to have the surgery done by an expert surgeon, because you need ideally to have the best surgeon possible to operate this really fine technique surgeon. And then after surgery, we're going to have the pathology, which means we're going to look at the tumor under the microscope, and then it's going to allow characterization of the tumor subtype. And there are many subtypes. I circled the two first, which are the most frequent, but there are 7 total. And some tumor subtypes will help us decide treatment. And some tumor subtypes we know they're more aggressive, so it's going to help us with the treatment choices. And then medical therapy, so it's often needed because either the surgery hasn't been completed successful, or there's a recurrent disease after a few years. What we have now are somatostatin receptor ligands. We have the first generation and the second generation. Somatostatin is a hormone that will decrease growth hormone, so it's going to be used for that purpose. We also have dopamine agonists that also target the tumor itself. And we have a third category of treatment, which is the GH receptor antagonist. So it's a blocker of the GH receptor. As you can see on the picture, I'm mainly acting on the liver to block the GH action, so there's going to be less IGF-1 produced. It's going to also have effect on other tissue also. So we have the two first one acting on the gland and the first one acting on the liver to decrease the IGF-1 production. The somatostatin receptor ligands, we have, like I said, the first and the second generation. The first generation are octreotide and lanreotide. They are injected either intramuscularly or deep subcutaneously every 4 to 6 weeks, approximately monthly. It's the first-line medical treatment in most patients. The efficacy to achieve biochemical control will be attained in approximately 40% of patients. So it's going to decrease the GH production, and it's also going to lead to tumor shrinkage in almost half of patients, which is good because we need to also control to prevent tumor growth. And there's a significant side effect profile. The injection can cause pain at the site, a lot of gastrointestinal symptoms that could be nausea, diarrhea, constipation, cramps, many others. There's a long list. I didn't list them all, but it's sometimes can cause a lot of side effects. We also have the second generation somatostatin receptor ligands. So the drug in this category is pasireotide. It's also on a long-acting form injected monthly. It's usually a second-line treatment if there's a non-response to the first generation. But we do have now predictors of response to pasireotide that also predict resistance to first generation. So the type of pathology, so the sparsely granulated subtype will be more responsive to pasireotide. The appearance on MRI, the T2 hyperintensity will also predict response. And if we do have on the pathology report the expression of this subtypes of the somatostatin receptor, because there's 5 of them, and some profile can predict response to pasireotide. So it could be used first line in some cases. And the efficacy will be to have an additional 20% control in patients that are not controlled on the first generation drugs. It would also lead to tumor reduction in half of the patients. The side effects are similar to the first generation, but the one that's more specific to this drug is hyperglycemia. 40 to 60% of patients will have higher blood sugar with the drug, so we need to increase glucose monitoring. So we'll teach you how to look at your sugar. If you have diabetes or pre-diabetes, it might need a dose adjustment. If you have acromegaly, you have an endocrinologist, which is an expert in also treating diabetes. So that's easily manageable for us. If we need the drug, we'll manage the side effect. Then we have cabergoline. Cabergoline is a dopamine agonist. So the effect of the dopamine will decrease GH secretion, also acting on the tumor. It's an oral drug, so it's a pill that's taken twice weekly. It's mildly effective, so mainly used for milder disease if IGF-1 is not too high but close to the target, or in combination therapy. So the efficacy is around 30 to 40%, but with mild response. Treatment escape, meaning at some point the treatment might not work anymore. This is quite common. And there's no tumor shrinkage reported with this drug. There are some side effects, so nausea, dizziness are the more frequent. We act on dopamine, so impulsive disorders also are some things we look for and we are careful about. It's reversible. If it happens, we stop the drug and this goes away. And we also need to look at the heart at higher dose because there's some risk of affecting the heart valves. The third category is the GH receptor blockers. So it's acting mainly on the liver. It's pegvisomant. It's an injection on the subcutaneous tissue daily, or can be also used in combination, often bi-weekly. It's usually also a second line or in combination therapy. It's going to decrease IGF-1, but GH will remain high because we're only blocking the effects of GH, not acting on the secretion itself. The efficacy will be in real life around 60 to 70% of obtaining control. And like I said, there's no tumor effect, so we'll need to monitor to make sure the tumor is not progressing. Other side effect we look for is what we call lipodystrophy. It's little lumps in the fat at the sites of injection, and we're going to monitor also the liver enzymes, so to make sure it doesn't increase with treatment. The last treatment modality is radiation therapy. It's the third line therapy. If we have a progressive tumor or remnant after surgery or an inadequate biochemical control on the maximum dose we can use of medical therapy. So it's really irradiating the tumor to help the control of the growth and the secretion. There's two types of radiation therapy. So the first one is what we call conventional radiotherapy. It's often a 20 to 25 course of treatment. So it's coming every day for 5 weeks for a small dose of treatment of radiation. The other type is radiosurgery. So that's very much more specific in terms of giving the radiation treatment. So the radiation dose, so it affects less the normal tissue surrounding. So it's our first choice if it's available and if the patient is candidate. So we need to look depending on the technology we use. In Sherbrooke, we have Gamma Knife, and we use quite often on residual tumor. That's not something we can operate on. And the efficacy to control the growth hormone hypersecretion will be long. So we kind of expect to have many, many years down the road to have an effect. With radiosurgery, we can hope for 80% control at 10 years, which is good, but takes a long time. And with conventional radiation therapy, mostly 50%. So this is for the growth hormone secretion, but for the tumor growth, it's going to be very effective. So in more than 90%, the tumor is not going to grow anymore. And we need to consider the side effects. The pituitary gland can be affected, so that the hormones can be decreased after the treatment. So we're going to look for this in the blood test regularly. And with conventional radiation therapy, down the road, there's long-term risk of affecting the blood vessels, so increased risk of stroke, a second brain tumor like meningioma or neurocognitive defects. So we keep this in third line if we really need to. That's a bit of an idea of the algorithm. I don't want to go in detail with that, but surgery is the first step for most patients. There are some considerations sometimes of using medical therapy also in first line, but I didn't went into this today. And after treatment, we'll usually use first generation somatostatin receptor ligands. If the disease is not controlled, we might increase the dose or shorten the dose interval. And then if the control is not obtained, we could change for the second generation pasireotide, pegvisomant, or combination therapy, let's say with adding pegvisomab to a first generation SRL. Cabergoline is also listed here, dopamine agonist in milder disease. And then if the disease is still not controlled, SRS refers to radiosurgery. So it's down in the lines of treatment. With all of this, we'll need periodic evaluations. So we'll have appointments, looking at the symptoms, the quality of life. We'll have a complete physical examination, taking blood pressure, many labs, the pituitary hormones, the cortisol level, the thyroid levels, besides the IGF-1 and GH. We'll look at the risk of diabetes, sometimes with a drug or without. We'll have periodic MRIs, many other tests, because we need to address also the other conditions, the heart, the bones, colonoscopy, looking for polyps. So there's going to be many things to add on the management over the time. And we'll be around with many other people helping us. So yes, you'll see your endocrinologist pretty often, but you'll also have I wrote neurologist, I wanted to write neurosurgeon, the radiation oncologist, and maybe other specialists to help us address all the other conditions related to acromegaly. And just a word on quality of life, because it's an important endpoint in the treatment, is the patient perspective on his disease, how he's living, his physical and mental health, cognitive function, how you feel, how are the energy levels, the pain, how he feels with the treatment. So this is an important endpoint. And I just wanted to highlight that there's some studies that show that there's a discordance between the patient and the providers. So not so much in the well control, but mainly in diseases that are partially or not controlled. So the patient usually thinks he's not as well controlled as the provider. So it's important for you to tell us how you feel. And overall, we aim for personalized treatment approach. So yes, medical treatment in the center, but many things to consider from the tumor, the patient point of view, the other biomarkers, the tumor, other conditions. So there's many things that we need to integrate to decide the treatment. But overall, we achieve good disease control. And I just wanted to show you, this is a Danish cohort. The white bars are it's studying over the years. So the white bars are in the 90s, in the 2000, and then the black ones are 2010 to 2021. So it kind of gives an overview of the treatment. I think it's representative of what we do here. So many patients had surgery. Some had a second surgery. Use of the somatostatin receptors is pretty high. Other drugs are a little less. And overall, over the years, that's a good news. The control is improving. So it went from 69% to almost 90% in the recent years. So we have more options, and we know more the disease and how to best manage it now. And there are also some things in research in terms of therapies. I won't go in details through this, but octreotide, which is the injection, is now approved in US in its oral form. So it's a twice-a-day oral pill. Many other drugs are also in research now. Combination molecules, some called paltusotine. So there's things that are going to come down the road. So in conclusion, screening for acromegaly is limited by its insidious clinical manifestations, rarity of condition, and lack of medical awareness. I think this is the most important thing that we need to improve, is increase screening. The diagnosis of overt acromegaly is made by elevated IGF-1 levels. Like I said, this is simple when we're there, but we need to have the IGF-1 levels measured. The cause is a GH producing benign adenoma that's located in the pituitary gland. And then treatment options are expanding. So we have surgery for most patients, then the somatostatin analogs, the first and the second generation that we can use, that are the mainstay of therapy. And then we can combine with cabergoline, prednisone when we need, and many new drugs in development. So it's exciting to see this research and improving care. And overall, besides normalization of IGF-1, which is one of the goals, and the perspective of the person living with the acromegaly is important for us in the management. So it's an important teamwork. So thank you. If you have any questions or comments, I'll be happy to take.
Thank you very much. Excellent presentation. I have a question.
You are prepared.
So you briefly mentioned that acromegaly affects the liver. So I'm wondering what the effects are of acromegaly.
Yeah. The effect of GH on the liver mainly will be for the production of the IGF-1 levels, but also it's all related also in the metabolic dysfunction. So the fat tissue, the pancreas, and the liver all act together in the control of the glucose metabolism mainly. So there's an increased risk of diabetes and high blood sugars that's in part caused by the insulin resistance in the liver. And GH itself, it's a hormone that's increasing the blood sugar in normal patients also. So overall, this is probably a lot related to the risk of diabetes.
So for the liver, fatty liver.
Mm-hmm. Yeah, so there's more fat in the liver. That's one of the explanations for the insulin resistance. It also causes lipid disorders, so cholesterol disorders that might be treated also, and that can be helpful with treatment.
Does anybody else have a question?
Hello. How often do people come in to be screened to not have acromegaly? Or is it often folks are coming in and have it? Like it's already.
It's a good question.
Yeah.
I don't think know the answer. I would say I think when people ask for an IGF-1, the clinical suspicion is probably very high, and the risk of having a high level is pretty high too. I personally am aware of the disease, and when I'm on call on service, I almost every week ask for an IGF-1 for someone that I see with diabetes, sleep apnea, other comorbidities. So I do have a lot of normal IGF-1 I ask for screening, but in general, I think when people ask for it, it's the clinical suspicion is so high, the risk of having a high value is high, and we don't screen enough. That's the end point.
I think that one day, I know that when we get older, we go in and blood test done. The annual high blood pressure, all that kind of stuff. Do you think that maybe in the future, if we all pull together, we could have the IGF-1 actually attached to the, panel of normal screening of blood work for middle-aged?
Yeah. It might not be effective in terms of screening. We tried, I know in my center, we did a little research study with people on the sleep apnea clinic. So we just restricted this to sleep apnea, and we asked a questionnaire for symptoms. And even with symptoms and the sleep apnea, we had a very low number of new diagnoses of acromegaly. In fact, the one we diagnosed were already diagnosed. So it's very difficult to target the good population to screen. So screening everybody is not the key, but that's why we we need more tools to and probably doing teaching to other doctors and specialists for them not to forget acromegaly exists.
Absolutely, I totally agree. First line of defense, GPs.
Yeah.
Anybody else have a question?
Thanks so much for the presentation, Dr. Langlois. Definitely really nice to hear kind of a lay of the land of the diagnosis side, the treatment side. So really nice to learn. Um, I had a question on something you had mentioned when kind of speaking about the diagnosis, which was in the IGF-1 tests. You mentioned there were some false positives sometimes. Wondering what those rates of false positives might be. Are there also any false negatives as well with the test? And do you see if there are any particular patterns, for example? Do you find if there's maybe a higher rate of these false positives or false negatives among patients that have maybe milder symptoms or more severe? Or are there any other markers we could kind of say on where the test may be or less effective?
Mm-hmm. Difficult to say for me what's the number of false positive. We just changed our assay in Sherbrooke, and I have more elevated IGF-1 than I think are just caused by changing the method. False negatives sometimes can be due to uncontrolled diabetes, so it's like a big glucose challenge test. Increased glucose over time will decrease GH and can lower and falsely normalize IGF-1. And like I said, thinking about liver function, estrogen, those are all things that are going to affect IGF-1. And then having low numbers, probably this exists, but it doesn't have as much as an impact. Yes, we do consider this when we talk about the growth hormone deficit, but it's less frequently a concern, I would say. But we diagnose more milder forms. Some of them are diagnosed because they had an MRI and we saw pituitary adenoma, and then we're doing labs, and you have an adenoma, you have high IGF-1. Maybe there's a link in between, but the IGF-1 is not that high. But this is kind of something where the knowledge is increasing, because it's quite new that we know about this condition, which is like a micromegaly, milder disease, less high IGF-1 than the florid symptoms and signs that we're used to see. So it's a different condition, and we know more about it with research. It's still going on because we need to know more.
Anybody else?
Thank you.